Great. Well, I know people are busy and have a lot of things to do, so I don't want to take too much longer to wait for folks to sign on. My name is Patricia Kalmar. I am the Senior Director for Healthcare Campaigns for PIRG, the Public Interest Research Group. We're a 50-year-old consumer advocacy organization, and in the healthcare space, we work on high-value healthcare, the intersection between what we're paying for healthcare and the quality of the care that we're receiving. Today's webinar is designed to be a quick overview of a really important policy relating to healthcare, a healthcare issue that affects many patients around the country, and that is the issue of ambulance surprise billing. We'll be joined today by our special guest, Assembly Member Tasha Burner from California, who is the sponsor of the California law that was just signed into law this year. So congratulations, Assembly Member. Would you like to introduce yourself to folks here on the call?
Yes, thank you so much for having me, and thank you everybody for joining. We are all very busy, and I love that we can still do webinar formats even post-COVID because it means that a lot more people can join rather than having to drive. My name is Tasha Burner. I represent Coastal San Diego and the California State Assembly. And it's so fascinating that we were able to get this bill across the finish line and signed by the governor. We tried for 3 years to do it. And I got my start in 2015 as a PTA mom who just wanted a stop sign near my kid's school. So it's amazing that we get to do this great work with great partners like you. So thank you so much.
Thank you. Thank you. So I think for the agenda today, what we'll focus on is I'll just do a quick overview of what is a surprise bill in general. I'll talk about the Federal No Surprises Act and what kind of protections exist right now and why we still have this big gap for ambulance surprise billing. And then I'd love to hear from the Assembly member again, just to hear about like how the campaign got started in California, challenges you had, things that you troubled over, so we can get some hands-on information from you for folks who are thinking about doing this in their own state. And then we'll take a few questions before the Assembly member has to leave. And then I'll come back and finish up with what's been happening on the federal level so that you have information about some efforts on the federal level to solve this as well. But we really see right now states are where it's at, and we'll be hearing a lot more about that as we go through. So just very briefly, what is a surprise bill? Um, a lot of medical bills are surprising to consumers, but there is a particular type of bill that's the most unfair and causes significant financial distress for insured families. Surprise medical bills are those bills that patients receive from out-of-network healthcare providers, doctors, hospitals, ambulances, laboratories. Patients get balance billed for the difference between what their insurance will pay that out-of-network provider and what the provider is actually charging. There were certain types of healthcare providers that tended to stay out of network because that enabled them to charge whatever they wanted, getting some money from the insurance company, but then demanding the rest of it from the patients. So these are what we call surprise medical bills. And too often, patients don't even realize that they're going to be getting this out-of-network care. Many times they're in a situation where they're either not choosing their provider or they're actually at an in-network facility and an out-of-network provider is treating them. So the cost of surprise medical bills, if we'll go to the next slide, were really expensive. And studies showed that emergency room bills were costing around $600. Surprise bills for anesthesia were more than $1,200. For childbirth, $750. More than 20 states passed protections against surprise bills, but those laws didn't cover all the residents in their state because depending on your state, many people might be getting their insurance through employer-sponsored plan. Those plans are exempted from state regulation. Sometimes they're called ERISA plans. So we definitely needed to supplement the states that were doing surprise billing protections with a federal law. And in December of 2019, Congress finally passed protections for insured people in all 50 states called the No Surprises Act. The new protections went into effect on January 1st of 2022, and studies by the insurance industry are showing that about 1 million surprise bills are prevented every month because of this important federal legislation that came after states had passed their own laws. So those bills, if you can imagine 1 million surprise bills being prevented, and we were talking about costs of 600 to thousands of dollars for surprise medical bills, that's a lot of money back in the patient's pocket. So the No Surprises Act is a great law, but it only goes so far, which is why we're having this conversation right now. So the No Surprises Act covers balance bills, prohibits balance bills in these situations. And in these situations, patients only pay what they normally would have paid if it was in network, their normal co-share, co-payments, co-insurance that they would have to pay if it was in network. So surprise billing protections exist in the emergency room, at an in-network healthcare facility where maybe your anesthesiologist or a scrub-in surgeon or someone like that is out of network, and then air ambulance transportation. But unfortunately, the law did not cover ground ambulance services. So if we go to the next slide, you'll see why it's so important that we have protections. About 3 million people every year are transported, 3 million insured people every year are transported to the hospital via emergency ambulances. In about half the cases, that ambulance transportation will be provided by an ambulance service that is not negotiated in the in-network system in your insurance. There's a lot of different reasons why many ambulances are not in network, but it is a real problem, as you can see, of about a 50-50 chance of getting an out-of-network surprise bill. And if we go to the next slide, I'll share a story about baby Theo. Here's his folks. Baby Theo was born prematurely, was having trouble breathing. And the doctors at the hospital determined that he needed the specialty care at the local children's hospital 16 miles away. Of course, his worried parents, Dave and Christy, were concerned and following medical advice said yes to the ambulance. And Theo was raced off to the children's hospital where, thank goodness, he's fine, doing great, and got the care that he needed in time. What they didn't realize was that the $7,000 ambulance bill the ambulance was actually out of network. So their insurance paid $1,000 towards that out of network bill, and they were responsible for the remaining $6,000. Now, when you talk to Dave and Christy, they already had paid their deductible for their insurance. Many of the emergency room and pediatric ICU costs were fully covered because it was an emergency situation in an in-network hospital. So they were seeing stronger coverage from their insurance and less out of pocket than they're seeing from this one ambulance ride. So this is this kind of problem that we were seeing across the country, and this is what we're trying to solve. So the prevalence of ambulance surprise bills, you can see here, it varies tremendously by state. That 50% chance of getting an out-of-network bill varies by the region, but for example, in Washington and Wisconsin, they have a much higher prevalence of out-of-network charges from ambulances. And the next slide, before we learn more about California, just shows you the variation in the median surprise bill, how much folks were paying in certain states, just a handful of states here you can see. In Maryland, they have an all-payer model. So that's one reason why the out-of-network rates were a lot lower, because there is some regulation of prices in Maryland. So now I want to turn over the microphone to our special guest. As you met earlier, California Assembly Member Tasha Boerner. She'll tell us more about the California situation and how she tackled the problem and brought protections to the people in her state.
Yes, thank you so much. I really appreciate that. And I'm going over the surprise bill. You know, when I was surprise billed in 2019, I had no idea what was going on. I had no idea this was a system-wide change. And, you know, a tip for the wise, it's not great to surprise bill an assembly member, you know, and I'm a mom. So yeah, that wasn't going to happen. But I didn't know what was going on. I thought it was a mistake by our insurance company because we had reached our family out-of-pocket maximum. And so I thought all of this would have been covered by the time we got the bill. My daughter, my first year in the assembly, had a rare eye infection. Thank goodness her father took her to the ER immediately, and they had to transfer, much like baby Theo. We had no say in it. They had to transfer to the local children's hospital for a 3-day stay to make sure she saved her eye and the infection didn't go to her brain. Um, and so I'm, in my first year in the assembly, trying to figure this all out, trying to deal with all the bills. And later that year, I have a district advisory council, and one of my local fire chiefs had come to us and said, "Hey, we have this problem. Most insurance companies won't contract with our city." This was the city of Oceanside, for ambulance services, and ambulance services in Oceanside is under the fire department. And so what's happening is people get these surprise bills that they can't pay. And so we're having to backfill the ambulance service for the city out of our general fund money because people can't pay for this. And so we started a 3-year journey to try to figure out what was going on, and found out that inadvertently in California, when they had passed all these surprise billing laws, they had forgotten about out of network ambulance services and what that means. So the first year it got held in committee because it's very expensive. Second year we worked on it. There was some argument over what would be the appropriate negotiated rate of reimbursement so that no ambulance charges would be considered out of network. So then we're arguing about what's the appropriate rate. This last year, what I think got it through is we, had 3 years of stakeholder meetings, and we're able to agree that our LEMSA rate, our locally negotiated rate, would be the reimbursement rate. And once that was clarified, that it wasn't flat rate setting, but it was based on what was already locally negotiated for reimbursement. We were able to get it through the system and signed through the Assembly and the Senate and signed by the governor. So it was a really long process, and it was very complicated because there was lots of stakeholders. I think in California, I'd say it did help that we were the effect of ambulance surprise billing does affect paramedics, and paramedics are often under the firefighters, and everybody who hates a firefighter, right? Like everybody loves their firefighters. And so politically, it was a very bipartisan issue here in California. And so I think that helped that it came from that. And it came from a story of me going and say, this happened to my daughter. And our witness in testimony, it happened to her daughter. And what was really important is exactly what you were saying, is in Fresno County in California, there is no ambulance service that takes federal healthcare plans. None. So there is no in-network provider in Fresno. And so when you look at that, you can make an intellectual argument or a theoretical argument of like you don't have a choice or whatever. But when you see a county having absolutely no in-network ambulance services, then it becomes very compelling. So we had a very compelling witness. We had, of course, it happened to me. It happened to one of my other colleagues this last year. And so really addressing it took a lot of years, a lot of meetings, 3 years of meetings to get it through. But ultimately, it came from a really authentic place, which is a fire captain worrying about the fact that we were underfunding the fire department through insurance companies not wanting to cover in-network costs and not negotiating with them either. They were not negotiating what would be in-network. And you think about it, a local fire department can't negotiate with hundreds and thousands of insurance companies for in-network. Everybody realized that was also really unrealistic. And so that's kind of the short form of how we got it through.
Thanks so much. Can you see me? Okay, great. I appreciate that conversation, and I think it's interesting. So this past year, 4 additional states, we see this map here, there are 14 states now with state ambulance bills. In this past year, we've seen the 4 states that joined in this protections all started to look at the local regulated rates, right? The locally set rates. And I think, if you could speak a little bit about another important part of California's law that will make sure that these local rates aren't just ratcheted up to backfill budget holes on the backs of insurance companies. Can you talk a little bit about there's a California law, I believe, that talks about not raising rates higher than the cost of servicing the ambulances?
Yeah, I mean, I don't, to be honest, that issue never came up in California in our discussions. So what the conversation, it wasn't, nobody thought the fire departments or AMR or any of our contracted rates were trying to make money off of this. Like, I don't think that wasn't a conversation that we had had. But we do have locally negotiated, it's called the LIMSA rate. I can't remember what it stands for. But we do have those rates, and they're quite different. Like if you go to Poway, and which is a kind of inland San Diego County city, that rate's 4,000. If you go to, I believe it's Encinitas, that rate is under 1,000. So you do have lots of variabilities in that, and I'm not clear it's actually like an objective standard of what determines that. Or I think it's like 750 if you were in the unincorporated county, and the 4,000 in Poway. That sounds more accurate. And so when we think about that, there probably should be some reforms on having that be more objective, because there's not any reason why Poway should be more, but that's just what the local process does. So I don't think anybody was thinking the fire departments or cities were trying to make money off of this, because we have these locally negotiated rates that most people accept. Most people accept that these locally negotiated rates for all of the services are objective and fair. So that didn't really come up in our conversations.
Okay, thanks. Yeah. So, because one important thing right now is that you're pointing to a rate. We know that whether the insurance company is in or out of network, they're going to get paid, and they're going to get paid something they can rely on now. So that's a really important thing, because I think, prior to some of these protection laws, it was a little variable how responsive the insurance companies were and how much they were actually paying. And that's why patients were ending up, footing pretty significant bills, because if they were out of network, insurance could kind of pay whatever they wanted. So I think we'll be having like a more secure system, emergency services system, when we are guaranteeing, some reasonable rates of payment for every ambulance from the insurance companies.
And that was part of the discussion in the first 2 years when the bill didn't move forward. And actually, I'll correct myself. The first year it didn't move forward was because it was 2020 and it was COVID. And so that's why it didn't move forward. The second year it didn't move forward because we couldn't figure out how to agree on the LIMSA rate. But it took us a while to figure out that was going to be the most fair and objective way to get this through. Because it's also a publicly negotiated process where the plans and the insurers have a say in the process, right? So they felt comfortable with that. And they didn't oppose either. I mean, I think that's important. I think, I didn't get the feeling like the insurers were being bad actors on this, right? I didn't feel like there was some like ulterior motive or conspiracy to really stick it to the patients. I don't think that was what was going on. It was, how do you have this, what can you use? In California, we do have this locally negotiated rate, which was so important. Local Emergency Medical Services Agency rate. That's what it's called. And so that was really, once we could land on that, I think that's what really made the difference. And when we think about it, you're saving a lot, and so in San Diego, we have some cities that are contract cities. They contract with private agencies for their ambulance service, but we have a lot that were within the fire department. And so once you have this idea of like, actually through this loophole, you're underfunding our emergency response. That was a very, very compelling argument, because it was never about overpaying. It was always about, we can't be underfunding this. And so it was interesting that it was the ultimate argument was less about patient, fairness to the patient and cost, but was more about what was fair to agencies and where's the backfill from that coming from.
Yeah. Important. I want to take a moment just to see if any of our attendees wanted to type anything in the Q&A for the Assembly member to answer specific to the California law or any of the challenges that they faced in passing this law, or what was the key to winning it. Feel free to put something in the Q&A feature. And if I don't see it, Mary Beth, who's helping us run this, you can read the questions out loud. I do think one really great part of your law is that you are going to be collecting all of these rates and having them in one place for everybody to be able to see. When this was starting to be debated in California, I was digging around trying to find these rates on websites. Not always easy to figure out where to find those rates. So I think it'll be great to have like one central place to see the rates and be able to know.
And I think what people often forget when they think about California is we have some very rural areas, and we have some very urban areas. And so what's I think really important is it doesn't matter if you're urban or rural, you're not going to get a surprise bill for ambulance services. And you're not going to undermine the provision of ambulance services either. You're not going to lower emergency response times or anything like that. Can we implement it in a place like Massachusetts, which somebody has a very large spread?
Yes, we have a question. Do
Yeah,
you think this legislation could be implemented in a place like Massachusetts, which similarly has very large surprise billing costs?
absolutely. What I would look for is do you have a local emergency medical services agency that determines rate setting? So that is whatever your objective rate setting process is, that's really important. So if you don't have that, probably I would advise to do that first. I'm assuming a state like Massachusetts does have something like that. And the other thing I would say is look at where your ambulance. I don't know the Massachusetts. I was just actually in Boston for a work trip a couple weeks ago, but what I don't know is how your townships, how your counties, how your different agencies handle ambulance services. Is it all contracted out? Do different counties provide it? Do different townships provide it? What's the difference between a big city like Boston and say Western Massachusetts? I'd say you look at that because you're going to have to have a system that works for everyone. And that's what our local emergency medical service agency actually did. But it did take us 3 years to find that that was the right thing, you know?
Thank you. Okay, well, right now I don't see any more questions. So if you have to run, Assembly member, thank you very much. We really appreciate it. Congratulations. Excellent victory. We're happy to collaborate with you and see this through. And we'll be looking forward to lots of protected surprise bills in the future.
Exactly. Thank you so much for your time. Really appreciate you having me on today.
Thank you.
Take care.
Okay, great. We will continue with our presentation then. So I did mention, if we can go to the next slide. So there, on the federal level, the No Surprises Act established a ground ambulance and patient billing advisory committee. And this committee has been working over the last 6 months our charge was to review options to improve disclosure of charges and fees for ambulances, to better inform consumers of insurance options for these services, and importantly, to protect consumers from balance billing. So if we go to the next slide, yesterday and the day before yesterday, we voted for recommendations from this advisory committee. I served as the consumer representative on the federal advisory committee. There were other stakeholders, large and small ambulance providers, fire chiefs, EMTs, fire, emergency room doctors, nurses, all sectors of the industry, as well as some of the federal agencies that are involved in implementing the No Surprises Act, Health and Human Services, Department of Labor, and Department of Treasury. After months of deliberation, these are the recommendations that we came up with in consensus voting to recommend that Congress make these changes and protect consumers nationally from surprise ambulance bills. I won't go through all of them, but you will be getting these slides, so you'll be able to look at them in more detail. But this is actually how the votes came out. There was a recommendation that we should be balance billing. If you could just go back one slide, we're going to be banning the balance billing of ambulances. We are recommending that Congress has a cap on how much the out-of-pocket cost is for the cost share for the patient per ambulance ride to the lesser of $100 or 10% of the payment rate. We have lots of good recommendations for what the bills should look like and that the ambulances can't bill the patient until they've already run the insurance through. And then giving patients information about their balance billing protections right there on the bill so that they have it right at the moment. And then under the No Surprises Act, there is a help desk which helps people figure out their billing problems. And so we're asking Congress to allow ambulance billing questions to go to the No Surprises help desk. And then if you go to the next slide, that talks about how do we pay those out of network ambulances. And the recommendation was insurers would have to make a minimum payment based on either a state law, if that exists, or an all-payer model. If that doesn't exist, then similar to California, this state or local ambulance rate, if it's set through a public process. If that doesn't exist, sometimes there's a single use case, like the ambulance might negotiate with the city that they're going to cover a particular concert or community fair, and they're going to have a negotiated rate for that event. So like single use rate for that type of situation. And then if none of the above, then the fallback would be if there's no state law or state or local rate, then the ambulance would be paid with a percentage of Medicare that would be set by Congress. Some of the state laws have Medicare rates at like 250% of Medicare, 350% of Medicare rates as a way to pay for private ambulance transports. And then making sure that the insurers are paying quickly, directly to the ambulance company. And if they don't, they could be subject to some fines. They did not set up an independent, there was no recommendation to set up an independent dispute resolution system to argue about these rates. These would be the rates, and that would be what the insurance company would have to pay and what the ambulance would have to accept with no balance billing to the consumer. So those are the recommendations, just a quick overview. Those recommendations will now be wrapped into a broader report, which will come out at the beginning of the new year, and then that will be going to Congress so we can start that process of perhaps getting a federal law. But PIRG always respects the states and the good things that you do in the states, and we know that we can get more states passing ambulance protections while we're trying to still get a federal law. And you all move quicker and smarter, and we can learn from your work. So we are doing this as an opportunity for you to learn a little bit more, to dive in a little deeper. If we go to the next slide, we'll move into Q&A for myself. And this is my contact information. Happy to work with you in any way that we can as technical experts, or to connect you with consumer groups in your communities that are interested in these issues to begin engaging on them. So I'll open up to Q&A. If you want to type anything in the Q&A, I'm happy to take questions.